This is Daybreak. Thanks for staying with us. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Dr. Samuel Mwenda is the General Secretary, the Christian Health Association of Kenya. Good morning, Dr.
Good morning.
Lovely having you here on the broadcast.
Thank you for
And many thanks for your company. Dr. Abdi Mohammed is the chairperson of the Social Health Authority Board. Good morning, Dr.
Good morning.
Much appreciated. Many questions coming your way this morning.
Thank you.
From the public and also from the seat. And also Dr. Brian Lishenga joins us. He's the chairperson of the Rural Hospitals Association of Kenya. Good morning, Dr.
Morning. It's a pleasure to be back here.
Pleasure to also have you here on the broadcast. So, gentlemen, we are discussing this morning one of the major pillars as highlighted in the President's manifesto, which was what he sold the Kenyan people and what he intends and seeks to actualize, that is healthcare, out NHIF in the new healthcare system, aided by 4 pieces of legislation that are now acts of parliament. And there were many concerns expressed by stakeholders, including the likes of Dr. Brian Lishenga, and I'm glad to have you here on the broadcast. First, we'll be getting the accounts of the healthcare professionals who appeared, the Minister of Health officials who appeared before the Senate Committee on Health yesterday. We'll be shortly getting that from my team here on the broadcast. But Dr. Mwenda, let's begin with the very obvious question of the problem of readiness as we had transitioned or continued to transition. On your part as the Healthcare Association that represents the Christian umbrella, how has it been in terms of the transition?
Thank you. The transition obviously has been a process. There has been, we worked with NHIF for many years, so we were very used to the systems of NHIF. Mm-hmm. We were involved in the discussions towards transition to social health insurance and a social health authority. But I think to us as service providers, the transition happened very abruptly. Mm-hmm. We had anticipated maybe a period of time when the 2 systems would work. And as maybe the system, the IT system that SHA is using, providers got more accustomed to it, capacity was built, systems were working well, then that transition would happen. So for us, we experienced a very sudden transition. There were a lot of teething problems. It has taken quite a bit of time for our capacity to build, for our institutions to properly get onboarded. But there's been improvement as we've moved along. Yeah. Thank you.
Dr. Brian Lishenga, the last time you had issued a press conference was in the aftermath of the statement by the President for the payment of providers less than 10 million Kenya shillings and the others subjected to audit verification for them to be paid more than 10 million Kenya shillings. Have the very same problems that you as an association had expressed been addressed, and does that satisfy your clarion call of service providers not providing services because of out-of-pocket expenditure?
Well, I mean, the main challenge, the issue of outstanding liabilities of from NHIF is not new. We've raised this issue since 2023. In fact, I was checking our records, and we, between the year 2022 and 2023, specifically held 5 press conferences on the issue of NHIF liabilities. So it was not a new issue. I hear some statements sometimes saying, like I had the PS say, you have had this debt since 2016, why is it a problem now? It's not unless he's the only new person in Jerusalem. It's not a problem now. It's been a problem since ever. We have been raising it. We have, in fact, this was not the first time we suspended services. Even when Dr. Abdi Mohammed was chairman CAF, he was on our side, suspending services as well because of NHIF liabilities. So, I mean, it is not a new thing that we are talking about. The only issue is that we noticed a policy posture by the Social Health Authority when it took over from NHIF, that seemed to distance itself from NHIF liabilities, which was not in line with, for example, what the recommendations of the transitional committee that was set up by CS Nahumicha then, sometime in February 2024, which was very clear. And if you look at that report, it says that the payment of NHIF liabilities shall be done. In fact, I'm using the language, shall be processed in the usual manner. Now, what was the usual manner? The usual manner was that claims that came in fast get settled fast. So the idea that the social authority would then distance itself from NHIF liabilities and put a priority on settling SHA claims, this is where now we started running into problems. And part of the explanation that we had been given was that money is money. Just use whatever you are paid by SHA to settle NHIF liability. But this doesn't work that way. If you have a service providers that is provided credit 2 years, 3 years ago, and you are using the same service providers now, and everybody knows this, even if it is your car repair, if you take your car for repair, they will tell you, you owe us money, please settle the previous liability, and then we can service.
Okay.
So the challenge has been that the push by SHA to distance itself from anything that it considers bad under NHIF is actually, you know, what has put us into limbo. There were things which were good under NHIF. There were things which were terrible. Just as under SHA now, we see some good things, but we also see some difficult things. That's just the nature of life.
We'll talk the good and the bad, or the ugly. Before I go to Dr. Ahmed, following the statement by the president from your providers, because if we look at NHIF, it was shut with over 22 billion in debt to providers.
More.
Okay, so let's go with that tentative number, because the report by the exit team will be highlighting on also the corruption part. So how many of your service providers or who are to be paid 10 million and below have so far been paid from your list?
Well, as at today, no one. Nobody has been paid. In fact, we were surprised that the statements that seem to be coming out of government would amount to threats and blackmail, you know, that you should continue. We actually lifted the suspension of services on goodwill. We had not received any money. We respect the president's commitment that, in fact, if you read the statement by His Excellency the President, it creates the impression that payments were to start immediately, that he has given instructions to pay. And then also the statement indicates that verification committee was to start work within a week. We are now, we are now more than 12, we are in the second week, 13 days in it. We don't have a verification committee in place. We have not received any payments for the facilities that, I mean, for NHIF arrears, that is, for facilities that are extremely distressed. So, in true sense of the word, the service providers, in response to the commitment by the president, and because patients are always number one, we said once, you know, and once the president has spoken, really, we are not going to split hairs about it, but it is our view that the instructions given by the president need to be implemented. And by the way, we are actually reviewing our position, reassessing our position, to see what next steps we can take.
Okay. So no service provider has been paid?
Nobody has been paid for NHIF arrears.
Daktari, good morning.
Morning.
Lovely having you here.
Thank you.
Can you tell the Kenyan people, have the service providers, given the directive by the head of state, been paid, the 10 million and below? The
10 million and below hasn't been paid, but it is a work in progress. The amount is around 5-point-something billion. We all understand that there are some processes. Exchequer has to release some funding to do that process. And the commitment still stands. The payment will be done and shall be done as instructed by His Excellency the President. And we were also very happy with the response from the providers by responding to that instruction, which shows goodwill, both from the provider side and from government side. And it will be done. I have no doubt that it will happen. Because the same thing happened, if you recall, just before October. We made close to 9 billion payments from previous NHIF, and that was done by SHA. So the accusation that Brian makes is we are distancing ourselves. There's nothing we are distancing ourselves, because we have inherited both liability and assets of NHIF. What we need to realize is when you have a law and you have government resources, you don't just wake up and say, I'm settling this using this money. That's not how public finance works. So when we say we are paying SHA liabilities, it doesn't mean that we are not going to pay NHIF liabilities. We are going to pay. And that's why the president gave that direction on how to proceed going forward on those liabilities. And this NHIF issue was predicted. In the NHIF We Want report, the panel of experts, which Dr. Mwendwa, I think Brian, myself, were part of it. And it clearly said that by the year 2020, NHIF will collapse if nothing is done for certain schemes. And it said by 2022, the whole thing will collapse because it's not sustainable. So it's not that no one knew that there was a problem, because the premium vis-a-vis the payouts were not commensurate.
Okay.
And you see, those are the things that with these reforms, including capping administrative cost to 5%, was meant to cure, so that you don't have SHA or the new entity using all the resources they get at will, whichever percentage that they would like to use.
To spend.
To spend. The second thing was to add some exchequer funding through primary health care and through ECCIF, so that you cushion what you are paying out from the premiums you collect, so that you don't depend on just premiums alone. You have a mixed model of financing. Okay. And that's why under SHA, despite the contract saying we will pay you after 90 days, we keep on settling every end of the month, because we understand the challenges providers are facing.
Okay. So, Daktari, let's now talk about primary health care, which is exchequer funded, as you had stated. And the first allocation following the bill which was signed into law was 4.1 billion to primary health care. This is level 2-3, a majority where people go to because of the close proximity in seeking medical attention. And there was the appropriations bill yesterday signed into law by the head of state, which also now adds or tops up another 3 billion Kenya shillings. Is this enough, given that the mindset of the people is now choreographed that once you go to these healthcare facilities, you're going to be getting the medical attention that you want? Is this enough?
For now, based on the number of people who have registered, yes. Because that exchequer funding, primary health care, is dependent on the number of people who have registered. It's not for the whole population, because if you haven't registered, it's not, there's no money, resources allocated. So it's based on the number of people who have been registered, and that's what we use now to pay. And I think we have already paid the first, and remember, it's for the whole year, based on the whole year. So one quarter is already gone. For the first quarter this month, January payments have been done. February payment is being processed, and then we will have March to do processing. So for this financial year, we're only remaining with one quarter. So going forward now, when it comes to the next financial year, what we'll have to look at is how many more people have registered and what are the resources we need for the whole year, not for 2 months, not for 3 months.
Okay.
Yes.
Dr. Mwenda, then, is this sustainable from your end, given that we have a paltry 3 million people? Now, or less yesterday. The acting CEO said 5 million out of the total 20.5 or 22 thereabout who have registered for this scheme. Going forward, as you had pointed out, is this sustainable?
Well, we need to get as many Kenyans as possible contributing to the social health insurance fund, because for other than the primary healthcare services that are being funded for by the Exchequer, the insurance part of the services, which includes diagnostics, admissions, procedures, deliveries, those are actually being paid for from the pool of the social insurance fund. And unless and until you are a contributor, an active contributor, you cannot benefit from those services. And therefore, we cannot grow our pool adequately to have enough funds to sustain this, supporting those who require to be treated using, a benefit from the packages provided by the fund. For primary health care, my wish is that because we know the Kenyan population, really we should not just be going by those who are registered, because tomorrow more will register. There should be projections. And we need to have adequate funds allocated and released in good time, because service providers require that capitation is paid on a quarterly basis. In fact, the complaints they have received very rich amounts of money for the population they're supposed to take care of, and they are still trying to understand the model because they are used from what they were used to before to what SHA has rolled out. So our appeal is that more of us, more Kenyans should register, should become regular contributors to the scheme.
All right. And Dr. Abdi, before I come to Dr. Lishenga, sorry. So your monthly collections is about 6.5 billion? Yesterday, the acting CEO said 7. Yeah.
So I'm happy, when you have experts, my explanation becomes less and less because Dr. Mwendwa actually has explained the people who are contributing, in as much as they are 5 million, have both dependents, and it's not 5 million exact, number one. Two,
more or less?
It's more, of course. When you have a dependent, it means there's an extra family, either a spouse or a child who is part of that family. But more importantly...
But the CEO says that there are 5 million.
Contributors.
Yes.
So what he is also explaining, and has explained very well, is that those are the people now who benefit from the shift part. The shift part is where now you need, these are the services, dialysis, surgery, imaging, cancer treatment. So it means not only do you have to register, but you also have to pay a premium. And when you pay a premium, is now when you unlock the second part of getting these extra benefits. And yes, I agree with him. I would like the people who have registered, the many more other Kenyans who just have registered but haven't paid, need to understand that for them to get now the second benefit, which is under the Social Health Insurance Fund, which includes inpatient surgeries, cancer treatment, dialysis, need to pay a premium for them to be able to get that benefit. So for us, what we are collecting is for those people who have paid premium are the ones who are going to get the benefit. It's not the whole 20 million who will benefit from this collection.
Because we'll talk about the modalities for the payment as well, and the case of Dr. Daniel Chacha here, which I'm sure within the quarters of the medical practitioners is a concerning case. So let's come back to the 5% capping that we talked about in terms of the administrative costing. And with the current collection of 6.5 billion, Dr. Abdi, this per month in terms of the tabulation, your administrative expenses comes to about 37.18%. And this surely, mathematically, how do you then make sure that you don't exceed that 5% capping? For example, given the numbers that they were given.
I haven't understood where that 7%.
What is your current monthly collection?
7 billion.
7 billion.
As the CEO said.
Yeah,
so
yes,
5% of it
5%.
is what we use for administrative fee.
Okay, we should not exceed the 5% capping, right?
5% of 7 billion is how much? 350 million.
Okay.
So we cannot spend more than 350 million on administrative cost. So the remaining 6.65 billion is for patients and providers.
Yeah. So you can,
I think so that it's clear that this 6.65 billion is for benefits, for claims that come from hospitals, whether they are private, mission, or public. Previously, that was not the case. Previously, the institution used to do its budget, including what they want to do. So they would look at 7 billion and they would decide what to do with how much. So they could go as high up as 20%. 20% of 7 billion is, if my mathematics is correct, 1.4 billion monthly basis. So you see, then the rest now becomes available to providers.
Okay.
And there was no even stop at the 20%. If something else comes up administratively, you just dip in your hand in that fund. And that's why for this structure, it is clearly demarcated that you cannot use money meant for this and use it for your personal emoluments, sitting allowances, and benchmarking.
Thank you.
You can't do.
Okay, when we get back from the break, Dr. Lishenga, I begin with you because the contributions is equally a very critical part, and we'll get the soundbite from the Acting Chief Executive Officer of the Social Health Authority, who appeared before the Senate Health Committee yesterday alongside the Cabinet Secretary for Health and the Principal Secretaries, P.S. Hari Kimtai and Mary Mudhoni, as well as Dr. Patrick Amoth, who all appeared to shed light on this very pertinent subject. We proceed with the discussion after the break here on the broadcast. Stay tuned.